Okay, I have some questions for you, but you cannot use your voting system just by raising the hands. 4 questions. You can answer by raising the hands. First one is, in case of acute right ventricular failure, fluid infusion may decrease cardiac output. Who votes for that? Okay, 1/3 of people. In case of acute right ventricular failure, fluid infusion may increase cardiac output. Okay. Third, in case of mechanical ventilation with Peep, fluid infusion may increase cardiac output through an increase in systemic venous return due to RV preload effect. Who votes for that? Yes, minority of people. Fourth, in case of mechanical ventilation with Peep, fluid infusion may increase cardiac output through a beneficial effect on Peep-induced right ventricular dysfunction through a RV afterward effect. Only 5% of people vote for that. Okay, we'll see afterwards the results. So which are the main cause of acute right ventricular failure in critical patients? Sepsis-induced myocardial dysfunction, right ventricular failure secondary to ARDS, acute pulmonary embolism, and also, deleterious effects of mechanical ventilation. And what is the challenge for us as intensivists in acute right ventricular failure? For me, the main challenge is to deal with the fluid administration and in the presence of right ventricular failure. Just to remind you the Frank-Starling relationship with this kind of curve for the right ventricle, there is preload responsiveness if the right ventricle operates on the steep part of the Frank-Starling curve, and preload unresponsiveness if the right ventricle is dilated. So if the right ventricle is dilated, fluid infusion should result in no increase in right ventricular stroke volume, okay? But we also have to consider the diastolic curve, ventricular curve, function curve. That is to say, right ventricular and diastolic pressure on the y-axis and right ventricular and diastolic volume on the x-axis. And we know that we have this kind of shape. If the ventricle is not dilated, the increase in preload in right ventricular and diastolic volume will not result in a huge increase in pressure. But if the right ventricle is already dilated, a further increase in preload will result in a high increase in the right ventricular and diastolic pressure, okay? So, in case of dilation of the right ventricle, fluid infusion should result in a large increase in right ventricular and diastolic pressure. So we have 2 statements. The first one is there is no increase in the right ventricular stroke volume because of the preload and responsiveness, and also the increase in volume due to fluid infusion will result in a large increase in right ventricular and diastolic pressure. Therefore, we can understand that because of the biventricular interdependence mechanism, we could have a decrease in stroke volume because the dilation, the further dilation of the right ventricle will impede the filling of the left ventricle, and there is, in this situation, a leftward displacement of the septum, and therefore you could have a decrease in the stroke volume of the left ventricle. So fluid infusion not only does not increase cardiac output, but can even decrease cardiac output. However, but, always but, in medicine, in case of inadequate, that is to say low RV preload, inadequate RV preload can be responsible for low cardiac output in case of acute right ventricular failure, such as pulmonary embolism. And therefore, if you give fluid to these patients, you can improve cardiac output. This is a study we did years and years ago with Alain Mercat, and we gave fluid to patients with acute pulmonary embolism, massive pulmonary embolism. You can observe that many patients increased their cardiac output with fluid infusion. And we found a nice relationship, inverse relationship, between the changes in cardiac index induced by fluid infusion on the y-axis and the baseline right ventricular endosteric volume index. That is to say, when the right ventricle was low at baseline, patients increased their cardiac output with fluid infusion. So we have to remember that. This is the phenomenon which was called the afterload mismatch. If you have an increase in afterload, you should have also an increase in the preload to counteract this increase in afterload. So if the patient is hypovolemic, the increase in afterload could be deleterious. So you have to infuse fluid to these kind of patients. Interestingly, in this study, there was no relationship between the baseline right atrial pressure and the changes in cardiac index induced by fluid infusion. So confirming that we know from many studies that right atrial pressure cannot be used to guide fluid therapy in septic patients, but also in acute pulmonary embolism patients. Another problem is a problem of mechanical ventilation, which interacts with all these complex relationships. And I have to just rapidly to remind you some effects of mechanical ventilation on the right ventricle. First, mechanical insufflation and the right ventricle, and second, Peep and the right ventricle. Mechanical insufflation and the right ventricle, we have two effects: mechanical insufflation and venous return, and mechanical ventilation and RV afterload. First, mechanical ventilation and venous return. This is what happens during insufflation, an increase in alveolar pressure with volume, with tidal volume, and this will result in an increase in intrathoracic pressure. And this results in an increase in the right atrial pressure. And this normally will impede the venous return. At the same time, you have an increase in the abdominal pressure during insufflation. And this could increase in mean systemic pressure, which is a driving pressure for venous return. And this would limit the decrease in venous return induced by the increased right atrial pressure. But the resultant effect, you know, is a decrease in venous return with mechanical insufflation. If I put this on this graph, which is the Guyton curve, but also the Frank-Starling curve, you know that we have a specific point, which is the equilibrium point, where the ventricle operates. This is a red point. This is a starting situation before mechanical insufflation. If you give tidal volume to the patient, you increase the intrathoracic pressure, and this will decrease venous return, like that. But because we also have an increased abdominal pressure, we have a shift of the venous return curve to the right. And this will, with the same Frank-Starling curve, this will result in a lower decrease in the cardiac output than previously. So we have a small decrease in cardiac output, Cu2, when we, for each mechanical insufflation. Okay, the same. If you give fluid, if you give fluid to these patients, you should have an improvement in cardiac output because you shift again the venous return curve to the right, and you increase the mean systemic pressure. Okay. Now, what about the effect of mechanical insufflation and the right ventricular ejection? We have to deal with the relationship between pulmonary vascular resistance and lung volume. You know that we have two categories of capillaries. We have extra-alveolar vessels and also intra-alveolar vessels. And if you increase the volume, the lung volume, for example, at each insufflation, you should have a dilation of the extra-alveolar vessels, but a squeezing of the intra-alveolar vessels. So, increasing lung volume would result, in fact, in improvement of the right ventricular ejection by decreasing the resistance of extra-alveolar vessels because of the dilation. And if I represent the venous resistance, the vascular resistance of the pulmonary vessels on the y-axis and lung volume on the x-axis, you have the residual volume, the FRC, and the total lung capacity. Okay, this is well known, and the resistance of the extra-alveolar vessels go down with increase in lung volume. But there is a curvilinear curve shape. But at the same time, because of the squeezing of the capillaries, the intra-alveolar capillaries, you also should have an increase of the transpulmonary pressure, that is to say the difference between the alveolar pressure and the intrathoracic pressure, and this increase in the transpulmonary pressure, which will impede the right ventricular ejection by compressing the intra-alveolar vessels. So you have two different phenomena at the same time. And this is the curve for the resistance of the intra-alveolar vessels. A small increase and an abrupt increase in the pulmonary vascular resistance of these vessels. And the resultant effect is like that. This is a U-shaped curve. This is a very classical relationship between the pulmonary vascular resistance and lung volume. So if you have tidal ventilation, mechanical insufflation, starting from the FRC, you should have a small increase in the pulmonary vascular resistance. Now, what about the pulmonary vascular resistance and the problem, the phenomenon of waist zone? Just to recall you that we have, because of the hydrostatic gradient from bottom to up, we have in fact 3 zones, which are the waist zones. In the zone 3, the alveolar pressure is less than the venous pressure and also less than the arterial pressure of the pulmonary artery. Therefore, there is no resistance and the flow is maximum. In zone 1, the alveolar pressure is higher than the pulmonary artery pressure because of the hydrostatic gradient, which is negative in this situation for the pulmonary arterial pressure and also higher than pulmonary venous pressure. This is zone 1. There is no flow in this zone, and the resistance by definition are maximal. And we have an intermediate situation, which is zone 2, where the alveolar pressure is higher than the pulmonary venous pressure, but lower than the pulmonary arterial pressure. And in this situation, the flow is not maximal. And the pulmonary vascular resistance increases from the zone 3, from the bottom of the lung to the top of the lung. Okay. So if we consider this waist zone phenomenon, we should have that in case of zone 2, 3, that in case of zone 2, and that in case of zone 1. And the resultant effect should be like that. So if I consider this waist zone, an increase in lung volume due to tidal ventilation should increase a lot the pulmonary vascular resistance. If you have many zone 1 in your lungs, and little increase if you have many zones 3, which is the case, for example, for congestive heart failure. In the case of congestive heart failure, because the pulmonary venous pressure is high, you should have only zone 3 conditions, okay? And of course, hypovolemia, the opposite is hypovolemia, will favor zone 1 and 2, because in case of hypovolemia, you should have a reduced pulmonary venous pressure, and therefore you could have many zone 2 and 1. In this situation, you have this phenomenon should amplify the deleterious impact of mechanical ventilation on right ventricular afterload and RV function. So we have to consider that for our practice. And you know that many papers showed that ventilation with high plateau pressure, higher than 35 centimeters of water, for example, is associated with a high incidence of right ventricular dysfunction or acute cor pulmonale, like in the study by François Jardin. And also, the mortality was higher in the group of patients with high plateau pressure, because in this situation, you impede the ejection of the right ventricle. And this was also demonstrated by the study by Antoine Verbaron using echocardiography, and he defined ACP, which is acute cor pulmonale, by an increase in the ratio of the right ventricle endothelial area over the left ventricle endothelial area above 0.6, and associated with the septal dyskinesia. And he found that the incidence of acute cor pulmonale in ARDS patients, despite a protective ventilation, is about 25%, so it's not negligible. We did not find the same results in a study we did with David Osman, and we included many ARDS patients and ventilated with a lung protective ventilation, but we defined acute cor pulmonale as the combination of a high mean pulmonary arterial pressure, higher than 25 meters of mercury, right atrial pressure higher than POP, and a stroke index lower than 30. In this situation, we found only 10% of patients with acute cor pulmonale. Okay. Anyway, reduction of transpulmonary pressure using ventilatory strategies aimed at limiting plateau pressure is associated with high reduction of incidence and severity of acute cor pulmonale during ARDS. And this is why the SSC guidelines, and I agree with these categories of guidelines, insist to target low plateau pressure and to use a low tidal volume to limit the effects of mechanical ventilation on the right ventricle. But we also have to consider the effects of Peep, and for example, the effect of Peep on venous return. And we know that by increasing intrathoracic pressure, Peep should decrease venous return and thus should decrease cardiac output, as I said previously, for mechanical insufflation. Also, the effects of Peep on right ventricular ejection. Maybe this could be more or less similar to the effect of mechanical insufflation, but here with Peep, we are on a steady state, okay? We are not in a cyclic state. So, again, the relationship between pulmonary vascular resistance and lung volume. If Peep overdistends the lungs, if Peep overdistends the lungs, you should have an increase in the pulmonary vascular resistance, okay? And thus, it's not beneficial. If Peep recruits lung units, you should have an improvement, a decrease in the pulmonary vascular resistance, because the end expiratory lung volume goes toward the theoretical R4C. Therefore, pulmonary vascular resistance should decrease. And you know that ARDS is a heterogeneous disease with some overdistension and some recruitment. So, what is the overall effect? If the overall effect, the net effect, is overdistension, pulmonary vascular resistance should increase. And in this situation, tidal volume ventilation further increases the pulmonary vascular resistance to high value in this situation of overdistension. But the opposite is also true. If the net effect is recruitment and not overdistension, pulmonary vascular resistance should decrease. And tidal ventilation in this situation should increase a little, only a little, pulmonary vascular resistance. But we know that the hemodynamic effects of PEEP are variable, depending on its capacity of recruiting or overdistending lungs, okay? This is what I said. Its capacity of improving arterial oxygenation, because you know that PaO2, if you improve PaO2, you can decrease the pulmonary vascular resistance because of the hypoxic vasoconstriction. Also, the degree of airway pressure transmission, adaptive mechanisms to PEEP application, and finally, also volume status. And I will finish by that. Because this is well illustrated by this study we published with Émilie Fougère and Xavier Monet in the past. We studied ARDS patients, ventilated with a low tidal volume. We started with a low level of PEEP, 5 centimeters of water, and we increased PEEP until achieving a plateau pressure of 30 centimeters of water. So we have a new situation with high PEEP, and the average value of PEEP was 13 in this study. And we perform passive leg raising in order to increase preload. And we measure the effects of passive leg raising using PA catheter and also using echocardiography. What we found, when we used high PEEP, we observe a decrease in cardiac index. And this could be due either to a decrease in right ventricular preload or an increase in right ventricular afterload. But we also observe an increase in pulmonary vascular resistance. So probably it was due to the increase in right ventricular afterload. And also we measured an increase in the ratio of the right ventricular endothelial area over the left ventricular endothelial area. So this confirms that probably PEEP increased the right ventricular afterload. And this is why cardiac output decreased. But, always but, when we perform passive leg raising, we observe an improvement in cardiac output, an increase in cardiac index, and not a decrease in cardiac index. And in fact, we observe a decrease in pulmonary vascular resistance. And we observe also a decrease in the ratio of the right ventricular endothelial area over the left ventricular endothelial area, confirming a decrease in the right ventricular afterload with volume. Probably what happened in these patients, it happens that volume loading favored zone 3 conditions by increasing the pulmonary venous pressure. It decreased the number of zone 2 conditions, and therefore it transforms these zone 2 conditions in zone 3 conditions, and therefore pulmonary vascular resistance decreased. So we have to remember that fluid can be helpful for decreasing the afterload of the right ventricle. So my question again, before finishing this talk, in case of acute right ventricular failure, fluid infusion may decrease cardiac output. Who votes for that? Yes, it can. It can decrease cardiac output because of the interdependence phenomenon. In case of acute right ventricular failure, fluid infusion may increase cardiac output. Yes, it can, because in some patients with acute right ventricular failure, there is some hypovolemia. You can improve cardiac output by giving fluid. This is a case I showed you in pulmonary embolism. Third, in case of mechanical ventilation with PEEP, fluid infusion may increase cardiac output through an increase in systemic venous return due to RV preload effect. Who votes for that? Some people. Yes, in the case of normal patient, not normal patient, but normal subject, if you put PEEP, if you apply PEEP, you should decrease cardiac output because of a decrease in venous return. This is a normal effect, okay? And fourth, in case of mechanical ventilation with PEEP, fluid infusion may increase cardiac output through a beneficial effect on PEEP-induced right ventricular dysfunction due to the right ventricular after defect. Who votes for that? Yes, this is the last case I showed you, in case of ARDS. So all the questions were, all the answers were yes in this presentation. Okay? My conclusion is that in case of acute right ventricular failure, fluid infusion not only does not increase, but can even decrease cardiac output. However, low preload can be responsible for low cardiac output in case of acute right ventricular failure, such as pulmonary embolism, and also in case of mechanical ventilation with Peep, increase in central blood volume with fluid may improve Peep-induced right ventricular dysfunction. Thank you very much.